Okay. Hello, everyone. I can go ahead and get started. Thank you very much for joining today's webinar, Working with Clients with Post-Traumatic Stress Disorder. As many of you know in our network, my name is Katie Litanga, and I'm one of the RMP program officers at ECDC, and I am also the health and mental health lead here. For today's discussion on post-traumatic stress disorder, we have partnered with Kristen Townhill, who is a licensed clinical social worker, and also the National Partnership for Community Training to provide you with this webinar. Kristen Townhill is a psychotherapist who serves as a clinical supervisor at the Florida Center for Survivors of Torture. She has worked extensively with clients with trauma and PTSD from torture, combat, and sexual abuse and assault. She has also presented to a range of professionals, lay people, and students on PTSD, complex trauma, dissociative disorders, and diversity. Today, Kristen is going to present on this very important topic for about 50 minutes, and then we will open it up to questions to the network, to the participants. During the webinar, it's going to be in listen-only mode, meaning if you speak, we won't be able to hear you. But this webinar service does have a chat function, so when we begin the Q&A, you will be able to send questions for Kristen through the chat box, and this is located on your screen on the bottom of the right-hand side. So when asking questions, you can send them to myself, and I am actually under Sue Kenny Salzer, the main presenter, or you can ask them to the entire audience, and I'll be fielding those questions. So without further ado, I'm going to go ahead and turn it over to Kristen.
Thank you, Katie. Hi, everyone. Thank you for having me. It's very good to be here. So my last name is actually Tohill. I saw it spelled back and forth, but I want you to be able to find me if you're looking for me. Right. So you already kind of presented me quite well. You understand I have a while working with PTSD, and over the course of that time, I've developed a framework that has really helped me understand the experiences of clients, and most importantly, help the clients feel like I know where they're coming from so that they don't feel alone with it. And so that's what I want to try to share with you today. So today's objectives are to enhance provider-client relationships and create more successful outcomes with refugees with PTSD, to provide an in-depth understanding of PTSD symptoms and their impact on the survivor, and to empower providers in making their own clinical decisions in the moment. What I mean by that is that I could give you a presentation just full of tips and things that I have figured out that you could do to help someone without any background on it, and I don't think it would ever be nearly as helpful as if I spent the majority of the time helping you understand from the inside how PTSD happens, and a lot better, kind of more in-depth understanding of what it feels like to have PTSD. So that rather than trying to memorize something that may or may not make sense, if you're relating to it and understanding things as they're happening with your clients, you'll be able to make your own decisions and feel comfortable doing so. So according to the Centers for Disease Control, PTSD and major depression are the most common mental health issues experienced by refugees. And this part is important both for those who are in clinical care and for those who are not, because there are many, many who are not in clinical care. And you, as the caseworker, are much more likely to come into contact with people who may be suffering with these things but aren't necessarily getting any therapy. So there are a long list of things that most refugees experience that predispose them to PTSD. These could include exposure to war, exposure to state-sponsored violence and oppression, torture, and I would like to point out that at least 10 to 30% of refugees in the U.S. are thought to be torture survivors, internment in refugee camps, human trafficking, physical displacement outside of their home country, loss of family members and prolonged separation, the stress of adapting to a new culture, possible lower socioeconomic status, and a high likelihood of unemployment. So according to the Diagnostic and Statistical Manual, 5th edition, which is the guidebook or the rule book that's used by all mental health providers and insurance companies, pretty much anyone that's working in an official capacity with mental illness the diagnosis of PTSD is a disorder lasting more than 1 month following a trauma characterized by 4 types of symptoms: re-experiencing the event, avoiding reminders of the event, negative changes in moods or thoughts after the event, and hyperarousal of the nervous system or overactivation of the nervous system. A trauma is a direct exposure to actual or threatened death, serious injury, or sexual violation, and this may be as a victim, witness, or at times even a perpetrator, depending on the circumstances. So I'm going to take you through 6 steps to understanding PTSD, starting with what we call adaptive information processing, and then going on to the panic response, dissociation, an experience that I call time capsules, which is actually about memory networks and the way memories are stored, the diagnosis of PTSD itself, and then complex PTSD, which is not in the DSM, but is very useful for understanding the kind of more complicated experiences of people who've been through prolonged trauma. First off, information processing theory. Information moves around through our brain much like food in our digestive system. If you think of food when we eat it, it starts out in a raw state. And different parts of our body have different jobs to process it and break it down into its components until eventually waste is disposed of and the nutrients are filed away where they belong. The same thing happens as we experience the world as it moves through our brain. So we experience the world through our 5 senses, right? This touch and taste and smell and vision and all those things. And our senses are actually controlled by organs, our skin and eyes and ears. So the brainstem controls all of our organs, all of our autonomic functions. It's what makes our heart beat and our stomach digest. Therefore, it's also what makes our skin feel. So as we sense the world, the information goes up into the brainstem, and then it moves into short-term memory. And when it's in short-term memory, it's very vivid and bright and clear and full of emotion. So if you and I were talking and you had just gotten in an argument right before I saw you, you would be able to tell me everything about the other person, what they were wearing, what you both said. And I'd be willing to bet you money that you would get angry all over again telling me about it. But as you told me about it, you would have to figure out what emotions you were having and put words to them and use your language, which is stored in your long-term memory on the other side of the brain, in order to explain your experience. So long-term memory is where we store language, like I said, but also our philosophy of life, our spiritual beliefs, everything that we've learned about how the world works. So the frontal cortex is on the front of both our right and left side of our brain, in other words, our short and long-term memory. And as we are figuring things out to explain them, it goes back and forth between the 2 sides, what the new information and what we already know, to label and make interpretations on things. So as we talked it over, you would be calming down more and more. And eventually, after I asked you some questions, you would remember that the person had been shaking really bad and that they had run into you and looked kind of startled. And that's what had started the words. So by the end of our conversation, you would be completely calm, and you would have decided something like, a very anxious person bumped into me and overreacted. And you wouldn't be upset anymore. You would have effectively processed that event. It would move over into your long-term memory. So in long-term memory, it's, like I said, it's distant, it's frequently gray. There's no more sensory information. There's usually just one kind of vague image. And then there's that interpretation that you made about the event. So that 5 years from now, chances are you wouldn't remember it at all. If you did, all you would see was maybe the person's face or the wall that you were looking at while you were talking. And you would say exactly what you had decided about it. Oh, yeah, I bumped into somebody in the hallway who was really anxious. And you wouldn't get upset telling me about it anymore because it had been processed. It's on the analytical side of your brain now. So that system shuts down as a part of the panic response. So when we're in danger, our body goes into fight or flight mode. It turns off a whole bunch of non-essential systems things like your digestion and your immune system that you don't need in the moment, and sends all of its resources to the parts of your body that are going to be involved in keeping you alive the best way that it knows how. So you'll get a whole bunch of physiological reactions, a flood of endorphins and adrenaline, your heart rate goes up, your blood pressure goes up, your breathing becomes short and shallow and rapid, your muscles tense, you may start shaking, you may sweat or feel very hot or cold, and your perceptions change, which is also to help you hone in on the danger, right? Things may appear louder, things you're looking at may appear brighter or like they're going slower. Some people will experience tunnel vision, which is where the mind is helping you by blacking out everything but the actual threat so that you don't get distracted and you can hone in. Now, the other thing that happens is that all of that blood that's up in the frontal cortex, right, which is in charge of executive functioning and decision-making because it accesses new information and makes sense out of it so that you know what to do, leaves that part of the brain, and it concentrates in the brainstem so that you effectively go on automatic pilot. The reasoning for this is primarily response time. You don't want to sit there and think about all the other times that you were in danger and then slowly figure out which one might be the best course of action this time. You want to let your body take over and just react, doing whatever it thinks is best. So when the blood leaves that part of the brain, the other thing that happens is that we're not really conscious or present to digest those experiences. So in other words, what makes us us is not there, so that we emotionally don't feel what we're expecting to have happen. We call that process dissociation. Now officially, according to the DSM, dissociation is a disruption in the usually integrated functions of consciousness, memory, identity, or perception of the environment. Now, if you think about that statement, it's very, very broad and talks about a lot of things, each one of those words, consciousness, memory, identity, include a whole bunch of factors of what makes us who we are or how we perceive the world, right? That's because dissociation is a very vague, abstract thing and can be very different for different people. And I think of dissociation as occurring on a continuum. All of us have had mild dissociation at some time, right? Because your consciousness alters at times when you're very focused on things. You might even be somewhat dissociated when you're in the zone, or when you have something they call highway something or other, right? When you zone out staring at the lines on the highway on a long-distance drive. Now, on the very extreme end of dissociation, we're entirely not present at all. Right? So if we fight our absolute hardest when we're in the panic mode, and no matter what we do, we can't escape or overcome the stressor, then the body turns off and checks out, and we freeze. So the best example of this is a deer on a road, right? If the deer is far enough away when it sees our car, you'll see the deer stop in the road a second and then run. But if the deer is very startled by the car and it's very close, you get the quintessential deer in headlights. What's happened then is that the deer's brain has instinctively decided that there's no way that it can get away from the car enough. So all the senses that would have been amped up as a part of the panic response are entirely shut down, and the deer checks out so that it doesn't have to feel the impending doom that it's assumed is about to happen. So another example I really like for that is, anxiety and anger are very similar to electricity. And there actually is electricity running through our body, right? That's how nerves send signals from our brain, and that's how the other signals in our brain interpret emotions, or the nerves make our arms move, and so on. So if you have a house with an electrical system and you take a whole bunch of air conditioners and blow dryers and microwaves and plug them all in, you'll have more and more electricity flowing through that circuit until eventually it hits a point where the circuit breaker flips, and it shuts it all down and the whole thing goes dark. That's exactly what's happening in our bodies. We get amped up and amped up and amped up to the point that we can't take it anymore, and it shuts down all of the panic response and checks us out, and everything gets really, really depressed and slow so that you don't have to feel the pain. So on this continuum, from slowly amping up to being completely frozen and checked out, the dissociation varies along with it, right? So some other examples of changes in perception that happen on this continuum are people during traumas who say that it felt like everything was happening in a movie, or like I said, it was going very slow, or that they felt superhuman, or that they were outside of their bodies. Right? So the self is disconnecting as a part of this dissociation to avoid the pain. And all that information that comes through into the brainstem gets stopped based on how far we're checked out or how dissociated we are. If we're still somewhat aware, all that information gets stuck in the short-term memory. If we fought our hardest and it's not working, if we've been captured or whatever it is, and we freeze, then we're entirely turned off. We're checked out, blacked out. When it's severe enough where we even faint and lose consciousness, then the information comes in and it gets stuck in the brainstem so that the person has amnesia for the part of the event when they were checked out. Okay? So what we end up with is something that I call time capsules. What I mean is all the data that we take in and normally dismiss, such as how old we are and all the different things that are going on around us that gets filtered out by our brain normally, doesn't get filtered out. It gets trapped, and it gets trapped together in their raw state, exactly how they are as they're experiencing them. All 5 senses, the emotions you're having at the moment, and please remember these are the worst emotions of your life, so absolute rage and terror, horror, guilt, grief, shame, anything you can see, right? Thoughts that you're having at the time or immediately afterwards, such as it's all my fault, or if I trust people, they'll betray me, and the level of panic that your body was in. So your physiological state, such as your heart rate and blood pressure. Anything inside of that time capsule can become a trigger. And a trigger is something that brings up the time capsule and makes you re-experience it again. So the next time you hear that song on the radio, or your heart rate reaches that high because you're nervous about something else or exercising, or you smell a particular smell, that can be enough to bring the time capsule back up so that you re-experience some of it, or in the worst case scenario, all of it. So now I'm going to talk about the different ways that people feel those time capsules coming back up. One of the most distressing ones is re-experiencing it. Right? When the time capsules are activated by triggers, or because the mind is trying to digest them the way it always does, people can re-experience their trauma in a few different ways. One of those is through our sleep, because REM sleep is one way we digest experiences. So people will have nightmares where they replay the event or situations similar to the event. Intrusive thoughts or images, what I mean is just pictures that pop up in their head out of nowhere. Flashbacks, which is reliving something that is inside of the time capsule. And that can also happen on a continuum, so that a full-on dissociative flashback is the person 100% inside the time capsule. In other words, they can't see anything that's happening around them, and they feel like they're transported back in time and are reliving exactly whatever it is that they're experiencing at that moment. Another one is physical panic in response to reminders, which is just your body going back to that physiological state of panic because of a trigger, or emotional distress, which is feeling the horrible emotions that you felt at the same time. Next up is avoidance. All bodies, everything alive avoids pain. That's what nerves are for, to tell us that things are bad. So if it's so intense, people are going to do all kinds of things to try to stay away from remembering them. So internally, avoiding means trying not to think about it or trying not to have feelings that remind you of it. External avoidance can be things like avoiding conversations or places that trigger you or certain people that remind you of it or seeing it on the news or in movies and that kind of thing. Next up is hyperarousal of the nervous system. That's about that electricity again, right? It's kind of like the body gets stuck with too many appliances plugged in all the time. Kind of stays in a semi-panic state. And there's a few different ways that we'll see that, including irritability and angry outbursts with little or no provocation, reckless or self-destructive behavior, excessive watchfulness, which is also called hypervigilance, jumpiness, which is called exaggerated startle, feeling like you're having a heart attack every time there's a loud noise or somebody comes up behind you, poor concentration and memory, so having a hard time reading a book or having very poor short-term memory, and insomnia, right? Because the body feels like it needs to stay aware all the time, so it can't relax enough to let the person sleep. Next up, negative changes in thoughts and mood. I break these down into two, one thoughts and one for mood. So the thoughts I think of as attempts by the mind to reduce conflict between the beliefs and what happened in the traumas or avoid emotional pain. What I mean is having our worldview shattered is a very, very painful thing. So we'll do some kind of crazy mental gymnastics to make it so that we can still feel safe or like our beliefs are still okay, which end up kind of biting us on the rear end. That can lead to a lot of guilt and things like that. So some examples of things that people do in their minds unconsciously, not on purpose, in order to reduce this conflict or to not feel the pain is not being able to remember parts of the trauma, having really, really negative beliefs or expectations about themselves, others, and the world, such as after the trauma, the world was just a darker place and I could never trust anyone and I'll never be the same again, that kind of thing. And distorted thoughts about the cause of the trauma that leads the individual to blame themselves or others. That's the one that I was talking about that bites you on the rear end. The idea is nobody wants to believe that absolutely horrible things can happen to good people who are being good people all the time. We would feel much, much safer if we could believe that we screwed something up, and that's why we had our trauma, because then we can go around believing that if we stay really, really tensed up and in control all the time, that we'll be safe and nothing else bad will happen. Negative changes in mood. Most of these changes have a significant overlap with symptoms of depression and the freeze response that I was talking about. People will have persistent, strong negative emotions such as the fear and guilt and shame. They'll frequently have a loss of interest in significant activities, things that they used to love doing. Almost all people with PTSD feel detached or estranged from others, kind of like when they checked out as a part of the dissociation, they never really fully came back and find it very hard to connect with others. And an inability to experience positive emotions, so not being able to feel satisfied or have fun, and frequently not being able to feel love, which can make a lot of people feel very guilty because they just can't access those warm feelings towards their family that they know they had before. So there are a couple things we call specifiers, which means special flavors that not everybody has, but we can point out if they do. One of them is that if the person continues to dissociate after the trauma, there are two main ways that they say that that could happen. One is depersonalization, which just means feeling detached from oneself, like I'm watching my own thoughts, or I'm always watching myself like I'm in a movie, or that kind of thing. Or derealization, which obviously feeling things are unreal, but kind of feeling like everything is dreamlike. Delayed expression can happen sometimes. That's when it takes more than 6 months for it to start or to fulfill criteria. That happens all the time when people are in danger for a very long period because their body just shuts it all down in order to stay on guard. So if they stay in the refugee camps for a long time or something like that, they might not feel the symptoms as much until they get somewhere where they're relatively safe, and then their body decides it can let its guard down a little bit. The other time you'll see it happen is if the person has another trauma. Traumas are kind of cumulative, so they'll end up fulfilling criteria for PTSD because of the recent trauma, but their re-experiencing will include old trauma. Complex PTSD. So Judith Herman did some groundbreaking work when she figured out that there was something going on with all of her clients who had had repeated trauma, especially people who had had very severe things or had had things that started in childhood. And many of the patterns that she was seeing led providers to blame the clients. People would get upset at their clients and think that they were doing things to get attention or that they weren't trying to help themselves. And she figured out that there's actually a really good explanation for what these clients were doing and presented it to the world, and many, many people have found it very helpful since. So complex PTSD happens when there's an extended trauma, especially where the person has little control, and it can cause long-lasting personality changes. And examples of that include prolonged imprisonment and torture, prisoner of war or refugee camps, and childhood sexual abuse. And it causes a disruption in our most basic sense of self, which comes up in a lot of different ways. One can be switching between different parts of the self so that the person has very rapid mood swings. Another can be very unstable relationships, impulsivity, repeated failures of self-protection, search for a rescuer, a sense of helplessness or paralysis of initiative. And I point that one out especially because I think that one can be very hard for anybody that is trying to get anywhere with the clients in terms of casework, right? They just get overwhelmed so easily that they don't know where to start, that they feel frozen still. And also hallucinations, things that seem like hallucinations. A lot of times you can relate back to the trauma. And I think I mentioned that in a moment. Yes, I will mention in a moment. So how do we apply this to your work? More than anything else, the most important thing is just using compassion, kindness, and unconditional positive regard. There have been over 1,000 studies that have shown that the relationship with the provider is the single best predictor of treatment outcome. So use the knowledge that you have to help you maintain the most helpful mindset possible, no matter what the person is kind of putting you through as they go through whatever they're suffering with. So one of the easiest ways to apply this to your work is that anytime you recognize any of the symptoms that we've been talking about, tell the person that it's normal. Show them that it's not a big deal, that you don't think they're crazy. Reassure them that they can handle it and that you can handle it with them together. Now I'm going to go through some specifics based on the symptoms that I just told you about. So if you're noticing physical symptoms of panic, you can model kind of self-calming and self-soothing. Just show them that you're taking deep breaths and that you're just sitting kind of still and relaxed. And if you want some hints on remembering or recognizing what it really feels like to feel some of those physical symptoms, I would encourage you to choose a really scary horror movie and watch how you feel physically and emotionally as the adrenaline pumps through you. Let's see, what else? Don't feel afraid to change the subject gently if it's appropriate. You know what I mean? If we change the subject too quickly, people will feel like you don't care about something that's very distressing to them. But if you sit with them a moment and show that you can stay calm and then say, you know, are you ready to move on so that we don't have to think about this right now or something like that, then you'll help them to distract themselves and get out of what they've been stuck in. So if you notice psychological distress, any kind of, you know, emotions, it's fine to be quiet and let the feelings be there. And that can be a very connected experience for someone to feel like someone sat with me and let me be upset. I also want to point out that different cultures, like I said, not only can describe things that somebody would think of as hallucinations, but also that when they're having flashbacks, they may think of them differently in a way that people would also think of as hallucinations, such as feeling like they're possessed by something or that they see spirits or that there's a demon that haunts them. Many cultures will also describe medical problems instead of emotional problems because so many things come up in their bodies. So in terms of thoughts, most people with PTSD will have difficulties with trust and feeling paranoid. So the best thing to do is always communicate clearly and openly and discuss things directly, such as talking about your different cultures and languages and everything, so that, and any time that you think some kind of misunderstanding might have happened, talk about it right away so that it's addressed before the person is likely to get overly upset and have a mood swing. And it also shows that you're trustworthy. If you notice somebody that's especially self-blaming, you really want to be kind of careful about challenging any unrealistic thoughts because it can be a way that they're trying to explain to you how distressed they are and they can feel invalidated by it. In terms of watchfulness and jumpiness, it can be good to be especially respectful of personal space, keeping a larger distance, and then just giving them kind of kind looks if you ever notice that they're easily startled or have been distracted by some kind of re-experiencing or something. If you're noticing the paralysis or the overwhelm or the self-endangerment that could get us frustrated, just remind yourself of what the symptoms might be like or the life experiences might be like that are putting the person in that place. And always be mindful that there is a higher occurrence of domestic violence and substance abuse in anybody that has PTSD so that people can be referred appropriately for any of that. I also want to point out that casework with people with PTSD directly helps them with their symptoms and helps them to unlearn what we call learned helplessness, right? So if people fight and can't get away and do that freeze thing, eventually they stop trying because it's so frustrating to try your hardest and not have it work. That's what learned helplessness is. So it's very hard to get out of that pattern once you get in it. And also, if the person is staying paralyzed and avoiding all the things that are scary for them, they never get a chance to confront it and show their brain that it's not accurate to go into a panic response in those situations because they're actually relative. So that was a very weird beep. I'm betting it's because we are running low on time. I'm almost done. Okay. So supporting clients and taking steps for themselves mediates the impact of PTSD by decreasing avoidance, as I was describing. Obviously, meeting basic needs decreases stressors. And then there's a lot of evidence that strengthening support systems improves resiliency. And I think most refugee agencies do a great job of working on family relationships and community involvement, encouraging people in their spirituality. So I had a very brief section on therapy. I'm going to skip that, and just if you have questions about therapy, encourage you to ask them, because it's already 6 o'clock, so we really need to move into the questions section. Are we there?
Yes. Thank you very much, Kristen, for that very informative presentation. We can open it up now to questions. As I said at the beginning of the presentation, if you have questions, you can use the chat function, and that is in the bottom right-hand corner of your GoToMeeting box. So you can send the questions to myself, Katie, but I am under Sue Kenny Fowler. You can chat them to the entire audience, and I can field them. But I would encourage you to ask questions now if you have them. And in the meantime, I'm gonna.
I might as well talk about therapy while people are typing. Is that?
Yeah, we could do that. I have a question. But.
Oh, you have a question? Sorry, I jumped the gun. Go ahead.
No, it's okay. I thought I'll ask a question while we're waiting on other questions. But my question relates more to the cultural aspect of doing casework with refugees. And I was just wondering if you've encountered or experienced any barriers when it comes to cultural understandings of mental health, such as stigma within the community, and if you have any advice for overcoming those barriers. As I've heard, as a former caseworker, and also have heard from caseworkers that can generally be an issue sometimes.
Definitely. Huge. And so one of the things that's been most successful is to not even call what's happening related to mental health. Groups are much more successful with many cultures that have a strong stigma against mental health. So creating some kind of group, a community group where people can meet with other people that they relate to that maybe are from their area or have had similar experiences, so that they are socializing. They're still doing a lot of really great healing work by socializing with other people. So that's the easiest way. And then when it comes to explaining it, if you really feel like somebody would benefit from a therapist, it's really going to depend on the particular culture of the person and the language, metaphorically, that the person speaks when it comes to suffering. So, for example, many Latin cultures are likely to somaticize. They're likely to not say, I'm anxious, but rather say, I have this stomach ache all the time, I feel tense all the time, or project it out more towards the family because of the family orientation, and say, I worry all the time about my wife. So then if basically you're starting with whatever the person's concerns are as well. Many people who have had a lot of stress in their lives have ongoing medical problems that bother them, especially things, tummy aches and tense muscles and things. And maybe there's somebody that you could talk to about the things that are most likely to give you a stomach ache, who would have ideas for you. And then when you're doing therapy with somebody that relates it more to physical, it tends to be that they also want you to be more prescriptive and give them specific things to do. So as a caseworker, you can also look into basic relaxation exercises and show them relaxation exercises and that kind of thing.
Great, thank you.
Mm-hmm.
Okay, another question from one of our participants. What types of non-counseling interventions have you seen to be effective? I've read a lot about circles/groups around cooking or other projects that are really therapeutic.
Exactly. So exactly what I was talking about. That any way that somebody can be brought into the community so that they're working on relating to others again will help them to heal. Trauma is healed only in relation to others. And there are a lot of different ways that people can either be learning different life skills or expressing themselves even if it's not officially directly about the trauma, such as I've heard of dance groups and art groups where you come together and just do what we call expressive art, which means don't worry about the outcome, just make whatever you want. And it gives people a way to get their feelings out without having to put it into words. So those are my two favorites. It's really good anytime you can involve physical action, and it's really good anytime you can help people express things nonverbally.
Great.
Yeah.
Thanks.
Mm-hmm.
Okay, moving on to another question. When people are dealing with a client that has learned helplessness, what are some techniques that can be used to help them?
Great question. So first off, you're going to be doing everything for them, but getting them to tag along and watch. And then every time you have any little tiny success at all, you talk about how it's a success and like what it feels like when you have a success, which is called amplifying. Whatever we pay attention to grows, whether that's a negative feeling or a positive feeling. So when we have a small success, when there's been a tiny amount of stress, say waiting in line before you talk to the person who's going to help you, they have just learned that you can face a stressor and overcome it. And so you want to really concentrate on how good it feels that it happened and how you were able to get a particular need met, and even, how you're proud of them for standing there even though it was so crowded and that kind of thing. And keep moving it up and slowly handing responsibility back over to them based on how much it seems like they're able to handle in the ways that they respond to you as you do these things together.
Okay, and one of the participants has a question about clients preferring to talk with faith leaders about these issues and not wanting to allopathic referral. How would you deal with this?
I am perfectly fine with that. Trauma always affects our beliefs about how the world works. Like, so many people find faith the most helpful thing that they can in looking for help and or in healing. As a therapist, when I come across that, at times I also find ways that people use their faith to beat themselves up. And it usually has to do with overly simplistic thoughts, like, well, I was taught that if I do bad things, I go to hell, so if something like this puts me through hell, I must have deserved it. So you do want to kind of check in and make sure that it is helping. But spirituality and faith-based groups and faith-based counseling offer more than a therapist can, in that they offer that sense of community also, which can also be healing. So it really, the most important thing out of any kind of treatment that a person does is that they want to do it. It's not going to help if they're not invested in it.
Great. One of our participants has a question if the participants will be able to receive an electronic copy of this presentation. So I just want to say that ECDC is recording this webinar, so we will send it out to affiliates after the webinar, and we will also be posting it online, so just to address that inquiry. And then one of our participants wanted more, she wanted to go back to when you mentioned indicators of PTSD, and that a person may have unstable relationships. Can you talk a little bit about that more and what that would look like?
Yes. So people with trauma, even who don't fulfill criteria for PTSD, or people with what we call attachment trauma, which is not that they were necessarily hurt, but their heart was hurt really bad by being separated from somebody, especially like a parent or caregiver, will do this kind of push-pull thing where they badly want to be connected with others, probably more badly than people who don't have attachment trauma because their heart is hurt there. But they get so nervous about it and so scared because it makes us vulnerable and you could get left again, that they'll jump way into relationships too heavily, and then when the least little bit of thing goes wrong that shows them that they could be in danger of getting hurt again, will totally go the opposite and decide that they hate the person. So they'll be very in and out, very intensely in love with somebody and then hating them, or back and forth with family members that they might have difficult relationships with, fighting with them and deciding they suck and then being around them again and that kind of thing. So that's worth addressing whether or not they actually have PTSD, and can frequently happen with somebody who's had to leave their entire culture behind because there's automatically an attachment trauma there because you've left not just your close family members but also what your world used to look like.
Okay. I'm going to rephrase this. How can caseworkers better deal with a refugee that has PTSD when accessibility to a provider, an appropriate provider, is an issue?
So are you talking about looking for the right therapist or helping them if they can't get the therapy?
I think it might be more of finding, I would say, culturally appropriate provider.
Okay. So you mean guidance on finding a culturally appropriate provider, or
yeah, I guess
about
like
helping them when they can't find that?
Yeah, like if you encounter issues with maybe there's not a provider within a certain locality of one of our participants who speaks the native language of the refugee. I guess more generally, and/or if there's just general issues with accessing appropriate mental health services. But I'm assuming for the specific population, we would be talking more about culturally appropriate and relevant.
Okay. So depending on what your funding is like, there are many providers who will do therapy over Skype. So you might be able to find someone who's somewhere else across the country who'd be willing to meet with somebody by Skype, but they can't bill insurance for that usually, so you'd have to set them up to private pay them. When that's not a possibility, I would look up anxiety management techniques, learning things like deep breathing and things like that so that you can show people how to interrupt the panic response. And then if they happen to want to tell you their story because no one else is there to hear it, let them tell it. And just show them that you can stay calm and survive it with them and sit through it no matter how distressing it is. And then you can also encourage them to express it in other ways when you're not there, to write it down, or to draw about it, or to share it with family members. Because if you remember, like I said, the more we talk about it, the more we get a chance to digest it. The important caveat in that, though, is that if we get too triggered by it and we turn off our thinking mind, then we just go back into panic trauma state and don't learn anything from it. So before you're encouraging anybody to do that, you want to make sure that they feel like they can handle it and they can self-soothe and that kind of thing, that they can stay calm talking about it.
Okay. Another one of our presenters has a question about additional studies and research to help the participants better understand PTSD, and how, like, for instance, how the participants can find translated explanations and aids to inform the refugee community about PTSD and give guidance to self-awareness. So if you are aware of any resources like that, that you can share with our network, maybe after the webinar, I think.
Sure. Well, the websites that I put on the resources page in the PowerPoint have a lot of great information. And the National Center for PTSD is directed at military, but they have a ton of handouts that are very simply worded for civilians so that that would apply to anybody. And you can use Google Translate to at least get a rough translation. Now, there's a website that has PTSD information in a bunch of different languages. And I can see it right now, but I can't remember what it looks like. So if I can remember what that one was, I'll get back to you. I'm pretty sure it's a government website. So like the CDC or something like that.
Okay, great. That would be great. Thanks.
Yeah.
One of our participants is wondering if PTSD is a condition that's often misdiagnosed. Maybe particularly in the refugee population, if you have any maybe ideas on that.
Yes. From my experience in community mental health before I worked in a PTSD specialty clinic, they were very unlikely to say just PTSD. They were much more likely to say that the person was bipolar or schizoaffective, or bipolar 2, which is like bipolar light, where you don't get as manic. Schizoaffective is a combination of hallucinations and a mood disorder, either depression or bipolar disorder. And the reason that would get confused is because people with PTSD have all that hyperarousal stuff in terms of not being able to sleep and having irritability and anger and things like that. And they also have mood swings all the time, which people usually think of as bipolar disorder. Because of what I said about how culturally many people will what we call externalize or take emotions and put them outside of themselves, either by saying that there's something wrong with their body or by saying that there's some kind of thing haunting them or something like that, many times they'll misdiagnose them with some kind of psychosis. They'll say they're schizophrenic or something, or that they have what they call somatization disorder or conversion disorder, where your body just fails to work at different times, where you have unexplained neurological symptoms. So if you think your person has PTSD and they're getting misdiagnosed, I definitely would advocate for you to get them evaluated further, because when it gets to the point of actually being PTSD, it doesn't really heal on its own. It needs some specialized treatment too, or some concerted effort to help it change.
One of our participants is hoping you can talk a little bit more about the term depersonalization and what exactly you mean by that.
Sure. So it means separating from yourself as a person. So that gets experienced in a lot of different ways. The easiest way to think of it is that if you believe that we are a soul and we happen to have a body, because somehow the person's brain separates them so much from what's happening that it seems like they as soul or spirit left the body and are watching what's happening. And that's experienced in different ways. So you've heard, everybody's heard the kind of classic out-of-body experiences like that happen with near-death experiences. It can be like that for people. People can go blank and just feel like they can't remember who they are for a little while. It can feel like you're a separate observer inside your head and you're watching your own thoughts. Very different for different people, but it means just feeling disconnected from oneself.
Okay, a little bit earlier, we had one of the participants ask a question around the cooking groups and the other more non-traditional projects. Mm-hmm. And she has a question if intentional trauma processing should be used in those groups.
Usually, no. The opinions have kind of swayed back and forth from therapists and experts in the field about that. There was a time where they did do trauma processing in groups, and they thought that the group members could support each other and that would be good for the community. But they found that people were kind of took on other people's trauma, or they were re-traumatized by other people's stories. So then they swung way to the other way and said groups are only for skills or talking about things vaguely and don't tell your trauma story. And now they're kind of, some people are thinking it still makes sense. One of the ways that it really makes sense to me is what we call testimonial or narrative exposure therapy. Because there are many cultures that have a storytelling tradition, if you were able to get a large enough group of people from a culture that did, it could be possible with enough support from the staff that you have on hand who can assess whether or not people are stable enough to do this, to have each person tell their story in the group setting or act out their story in the group setting. But I would really, really advise consulting with a therapist before you ever attempt that, because it could be you could have a big, big mess.
Okay. We're actually out of questions, so I would encourage anyone to go ahead and pose their question to Kristen before we wrap things up. In the meantime, while we're waiting to see if we have more questions, I have a question that's related to gender. I have a bit of a background in gender myself. So I'm just wondering if there have been studies or in your experience if you've seen kind of a differentiation in how PTSD is presents in refugees between men and women. or if they deal with PTSD in different ways, or if it's looked at in kind of a gender analysis way.
So I have seen studies about that, about PTSD in general, but not specifically in refugees. So I think the things I'm going to tell you about what they've said about PTSD and gender in general are going to apply to refugees also, especially if you think about gender in general in the particular culture that the refugee comes from, that many times if the gender roles are more pronounced, then these differences will also be more pronounced. So in general, women tend to get PTSD more than men. And frequently women and men tend to show their PTSD in different ways. Women are more likely to feel depressed and to self-injure or get in other hurtful relationships. And men are more likely, and I think personally that this could be testosterone, but it also is very highly likely that it's culturally related. They're much more likely to feel like it's more appropriate for them to share their distress by acting out. There can be the opposite also, that men, there's more of a moratorium on men talking about their feelings than women, so men may really shut down with it and not share anything with anyone. Well, those are the biggest differences I see.
Great, thanks.
Mm-hmm.
So if I don't see any more questions, so, oh, sorry, just got one more. So one of the participants mentioned that you just spoke about narrative exposure therapy and would like to, what are some of the other approaches used in group settings, and how would you develop psychosocial measurables?
Great questions, my goodness. So I'm going to start off concrete and then go towards the more abstract processing stuff. So as we all know, meeting basic needs radically decreases people's stress level and so can help them cope with everything better. So, and you may also have heard of Maslow's hierarchy, right, where he said that we all need things like food and shelter and physical safety first, and then we can deal with things like emotions and then becoming our highest self, they call self-actualization. The same thing definitely applies when we're dealing with casework. Obviously, people recognize that, or else there wouldn't be so much casework for refugees, right? So we want to think about the same thing as we're working on groups. So you want to do a little bit of a needs assessment in terms of what your main population is, about where they're at, and form your group based on what's going to meet most people's needs in that way. So it may be that they need to practice English or learn about American culture or that kind of thing. So the measurables are always, a lot of people talk about this, right? Specific, measurable, attainable, you know what I mean, realistic, and time limited. So help them think of concrete things that they can see happen because they're having a difficulty with communication or cooking or, the government system, whatever it is, and actually work together on projects that help them to confront that. So if they're getting together to practice their English, then everybody can meet, practice their English, and you can do very, very simple surveys about how comfortable do you feel speaking English in public, on a scale of 1 to 5, how would you rate your English language skills and things like that, and just do a pre and post test with it. So as you build up, you could do similar questions about just feeling related and connected to other people. And you could ask, do a pre-test about, if you feel isolated or if you feel like you can communicate with others. And then the group would be presented as a support group. They could just get together and talk about whatever they wanted, and then you do a post-test on the same issues. Building up to kind of the more abstract or psychologically oriented, if you feel like people are ready to learn specific coping skills for anxiety and anger and that kind of thing, you could get together for a coping skills or relaxation group and ask them about how confident they feel, how comfortable they feel taking care of themselves when they're distressed, and if they feel like they have the skills to deal with their own distress level or stress level and that kind of thing. If you're doing an actual therapy group, you can also use, and I think you guys use the Harvard Trauma Questionnaire, but the PTSD checklist and all those are pretty much the same, which is a 17-item inventory of PTSD symptoms, and you could measure how bad their PTSD symptoms were before and afterwards. Or many, many people are more likely to relate to depression symptoms than PTSD, and there are a number of free depression scales out there, like the Beck Depression Inventory, that you could use before and afterwards, that kind of thing.
Great. Okay. Sorry. Let me see. One just came in. So one of our participants is asking more or less about the prognosis for PTSD. So they're asking if there is a cure. So maybe if you could talk a little bit about treatment for PTSD and just the general prognosis in your experience of working with clients.
Mm-hmm. The more I work with it, the less sure I become about what the prognosis really is. I have definitely, with the majority of my clients that I've done trauma-focused therapy with, been able to get their symptoms to the point that they no longer fulfill criteria for PTSD, but usually there's still a little something there. I don't present clients to this way, so this is kind of for your understanding and not something I would ever say to a client, but you can think about it kind of similar to cancer, that it goes into remission, but it kind of lurks there, and then anytime the person has a stressor of some kind, if they start having money problems or break up with their wife or something like that, their symptoms will flare up. So it's kind of like a chronic condition that will be in remission for a while and then flare up when there's additional stressors. The thing I will say to patients is, obviously you will never forget this. However, we find that people's view of the world gets very, very dark with the trauma. Like it stays honed in on the trauma, like a telephoto lens that breaks and can't zoom back out. And there are ways to zoom back out so that you can see the good parts of life again, right? If we think of black and white thinking, we feel like we were innocent and ignorant before the trauma, and then we feel like the world is an entirely dark place afterwards. Stepping back and zooming out can help us to find that gray area where there are bad things that happen sometimes, but there are also things that we can enjoy in life and things that are worth living for. So I think it's good for people to kind of set up that understanding, like that you totally can have a productive life with this, but you know it's a stress disorder, and there could come a time when you're stressed out that you might start having nightmares or something again.
Okay, I think we have time for maybe another quick question. One of our participants wants to know what you would recommend doing if a refugee refuses to admit that he or she may have PTSD, or if they refuse to seek treatment.
Mm-hmm. So social workers are really big on the idea of starting where the client's at. When we're in denial about things, it's because some part of us has decided that we cannot handle it, that we will cease to exist as a person, that we will be shattered in some way if we allow ourselves to admit it or if we allow ourselves to remember it. So we don't push against that very hard at all. Instead, we deal with whatever they're willing to deal with. So more than anything, I always start people with education and basic skills, right? I have all those symptoms of panic that I was talking about. Only a few of them can be changed consciously. Those are the breath and the muscle tension. If you do that, your body stops giving the signal that there's a danger, and the other symptoms can also decrease. So deep breathing can lower your heart rate and blood pressure and all those things. So you can present something like that as something that anybody might like for stress or relaxation. Oh, you look like you're tense a lot of the time. Would you like to see something that works for a lot of my clients? And then when the person mentions or reports or you observe something that seems like indicative of PTSD, you don't have to name it. You can say, oh, you just did something that a lot of my clients who have trauma do. You just jumped so much when that door closed. Did you have some kind of feeling in your body, or did it startle you real bad or something? And then, the more you relate your observations to what's happening, it kind of opens the door for them to make the connection a little bit at a time if they're ready to do it. But you don't need to push. They'll do it when they're ready, and if they're forced to do it, they'll just be re-traumatized. I know that's easier said than done because we're the ones that are kind of left dealing with the mess and picking up with the pieces when the relationships are disrupted and the person continues to suffer and that kind of thing. We just ease into it with education and let them decide.
Okay. So I think that about wraps up our time.
Oh, I thought of one more thing.
Oh, sure. Go ahead.
Motivational interviewing is fantastic for case management. Motivational interviewing is about not pushing. It's totally about where the client is at. It's about asking people what it is that they want out of life and helping them to get excited about it. Because what we find is as soon as somebody feels pressured to do something, they're going to expend their energy resisting rather than doing it. So instead, if you kind of move them out of the resisting point and get them thinking about the things that they want back that they're missing out on because they have untreated PTSD, I'd really like to see my family, or I'd really like to be able to go to the park and that kind of thing, we can help them to get to a place where they're the ones kind of coming up with the idea.
Okay. So I think that about wraps up our time. And I just wanted to mention one thing about motivational interviewing. We actually had a conference call a few months ago about that, so I can send out some detailed notes with the resources we'll be sending out after the webinar. And also, it was just brought to my attention that the National Partnership for Community Training also has an information guide on forming groups, and also tools for referrals and screening. So I can send those out to the affiliates as well. But I would just like to thank the participants for joining, and especially Kristen, thank you again for joining us and helping us to better understand this very important topic. I'd also like to thank the National Partnership for Community Training for helping us to arrange the webinar. And just so our participants are aware, I'll be sending out a survey, an assessment of the webinar. So please be on the lookout for that. And just to mention again that this webinar will be available online through ECDC's website, and I will also send it out to affiliates so you have that for your reference. So Kristen, if you wanted to mention anything else. Okay, well, I think that about wraps up our time. Thank you all very much for joining, and have a good evening.